Hello friends, today we are going to discuss something about the gallbladder. So most of the time, the gallbladder pathology is very important in hepatobiliary system. Most of the time, this as the histology goes, it lacks the muscularis. Most of the time, the function of this gallbladder is it stores the bile, concentrates the bile, and releases of the bile whenever the call comes from the second part of the urine. Gallbladder, the pathology of gallbladder as pathology of gallbladder is very important in hepatobiliary system histology. As we take, it lacks the mucosal layer and it contains only the mucosa, smooth muscle, perimuscular and serosal layers. Its function mainly to store the bile, to concentrate the bile, and release the bile. Some congenital abnormalities can be seen in the gallbladder. Sometimes it may be completely absent, sometimes it may be present in some of the abnormal positions like the parenchyma of the liver, and it can be embedded in any way in the liver parenchyma. Other variants here is a folded fundus. Sometimes it looks like a mass arising from the fundus. So usually this is what we call it as a Phrygian cap. This is a folded fundus. So sometimes duplication of the gallbladder can be seen. Sometimes bilobed gallbladder. Sometimes agenesis completely the gallbladder, hepatic duct as well as common bile duct, and some of these ducts will be hypoplastic or sometimes narrowing of the whole biliary channels. Next slide. So the time the polylithiasis, the gallbladder stones. So 95% of hepatobiliary tree diseases attributable to the gallbladder stones, otherwise it is known as polylithiasis. Okay? The polylithiasis, 10 to 20% adult population are attained to this gallstones in developed countries. So among this, 90% of the gallbladder stones are cholesterol stones. So among it, 50% are cholesterol monohydrate stones. So 10% are pigment stones. They are nothing but the bilirubin added to the calcium salts. So majority of the gallbladder stones, otherwise it is known as cholelithiasis, remain asymptomatic for decades together. So if we take the pathophysiology of this cholelithiasis, especially the cholesterol stones, is a very good flow chart that depicts how the gallbladder stone, completely the cholesterol stone will form, especially in biliary tree. So this bile lipids added to this bile salts, lecithin, cholesterol, the saturation of supersaturation of cholesterol appears and multilamellar vesicles will forms. So this is added to this the gallbladder hypomotility and cholesterol nucleation. Cholesterol nucleation. So solubility of the bile salts when it surpasses the cholesterol content, it will give rise to cholesterol nucleation. That nucleation is responsible for crystallization of cholesterol that will form the cholesterol monohydrate like filaments, sometimes plates. So it promotes most of the time the hypermucus secretion, gallbladder hypomotility, and calcium salts along with the supersaturation of this bile salts will give rise to a hard, pale yellow cholesterol stone as a cholesterol stone. So, what are the risk factors for getting this cholelithiasis, otherwise the gallbladder stones, most of the time? The Native Americans, especially 75% Native Americans, they are much more prone to get this cholelithiasis, especially the 75% Hopi, Navajo, or Piwa groups are much more prone. Second one is industrialized countries and increasing age. Females more than the males, 2:1 ratio. Estrogen influences most of the time the pregnancy and oral contraceptive pills. And then obesity, the metabolic syndromes, hypercholesterolemia, and rapid weight loss is also one of the causes of cholelithiasis. So, gallbladder stasis is very important risk factors for cholelithiasis. So, hereditable, usually concerned with hepatobiliary transport, the two adenosine triphosphate ABCG8 gene. So, most of the time, there are types of gallstones. First one is pure gallstones. Second one is mixed gallstones. Among pure gallstones, the commonest 90% is cholesterol stone. Among the 90% cholesterol gallbladder stone, 10 more than 50% are pure cholesterol stones. And then among these 10% pigment stones, most of the time pigment stones are nothing but bilirubin with calcium salts are known as pigment stones. These pigment stones will be seen in case of hemolytic anemias, sometimes infections like this pyogenic bacteria, sometimes parasitic infestations like Ascaris, Opisthonorus sinensis, and E. coli are responsible. Next. In case of cholesterol stones, the pathogenesis revolves around the four factors. The first one is supersaturation of bile. So, supersaturation of bile occurs when solubility of the bile salts overacts with cholesterol. So, the second one is hypomotility of the gallbladder. Hypomotility of third one is cholesterol nucleation in the bile, and the mucus hypersecretion in gallbladder, which will trap the crystals and promoting to aggregate as stones. So pigment stones, the pathology most of the time usually is it is in the setting of unconjugated hyperbilirubin. Most commonly, it may be due to chronic hemolytic anemias like hereditary spherocytosis, thalassemias, sickle cell anemias. So, precipitation of this bilirubin with calcium salts are nothing but pigment stones. So, in underdeveloped countries, these stones form due to the infections of Ascaris, Opisthonorus sinensis, E. coli, which will promote bilirubin glucuronide with deconjugation. So these are the cholesterol gallstones. If you take the morphology of these cholesterol gallstones, purely it arises within the gallbladder. Gallbladder, classically hard and pale yellow in color. If it imparts with the calcium salts, it will be black color, these cholesterol stones. When predominantly pure cholesterol stones, it will be radiolucent. 10 to 20% usually it will be imparted with calcium salts, thereby it will give rise to a black color to the cholesterol stones. These single stones always avoid, and multiple stones, these cholesterol stones, are all faceted, multifaceted. The pigment stones, mixed stones usually may be black, maybe yellow, maybe brown because it contains calcium salts as well as the bilirubin as well as the cholesterol stones. Next slide. This is the histology of the gallbladder whenever it contains so atrophic mucosa with this serosa is inflamed. Next slide. This is chronic cholecystitis. So most of the time, this chronic cholecystitis, the mucosa will go out pouch inside the muscularis that will give rise to a sinus, which is known as Rokitansky shaft sinuses. This will be seen in chronic cholecystitis. Next, cholesterol stone. Most of the time, cholesterol stone is pale yellow color, ovoid in shape. This is obstructive gallbladder. That's why it is dilated. Next slide. These are the pigment stones. Morphology. So most of the time the pigment stones can be black, sterile in gallbladder, bile or brown whenever it is infected. So these pigment stones are always soft, multiple, 50 to 75%. These pigment stones are radiopaque. Here, plenty of stones are there, multiple stone, black color. Next, the impacted gallstone, you see, very big stone, it has been impacted, and the liver parenchyma is showing the abscess formation. So, the catastrophic complication of gallbladder stones. These are pigment stones. So definitely it is black color, it is white in shape. Most of the time it will be soft to touch. So 75% of these pigment stone, gallstones are radiopaque. See, multifaceted, mixed gallstones, gallbladder dilated, and its walls came gray white. Typically, it is chronic cholecystitis with mixed gallbladder stones. Cholecystitis, most of the time acute cholecystitis, chronic cholecystitis. Acute cholecystitis is acute inflammation of the gallbladder. So most commonly it is precipitated by stones obstructing the biliary tree. So 10% of this acute cholecystitis may be acalculous. So acalculous means without a stone formation, there may be inflammation of gallbladder. So most of the time, this acute inflammation of the gallbladder occurs whenever there is increased secretion of mucus, increased inflammatory mediators like leukolecithin as well as the prostaglandins. So this is due to the ischemia caused by the endarterial cystic artery supply. So the distension will occur. Sometimes the bloody mucus accumulation will follow the acute cholecystitis. So the bacterial contamination sometimes is a late sequelae of acute cholecystitis. So acute acalculous cholecystitis, it occurs whenever there is ischemia in endarterial cystic artery circulation. So it can be seen in the setting up of the sepsis with hypertension and multi-organ failure, immunosuppression, major trauma or burns or diabetes or infection. So the 10% of the acute acalculous cholecystitis can occur in the patients with the severe trauma, severe burns, major surgery, diabetes, and sometimes the infections. Immunosuppression also one of the causes for acute cholecystitis. So, in case of this, if you take females are more commonly affected. The 5 F's are very, very important. Female, fertile, flatulent, and fertile. 90% associated with gallstones. Only 10% we can say it is acalculous acute cholecystitis. But it can happen. So bacterial infections, most of the time, it follows late sequelae. So whenever a female aged about more than 40, 45, so come with pain in the upper abdomen, epigastrium, so a colicky, torrential pain, colicky spasmodic pain in upper abdomen as well as epigastrium, It radiates to the right shoulder and to the back. So the patient may have fever, leukocytosis, mild jaundice due to the obstruction of the biliary tree. So whenever we take any ultrasound, the gallbladder is dilated, swollen, fibrinous exudates are there, the gallstones will be there. So if we take the histology, there will be transmural neutrophils as it is acute cholecystitis and luminal exudates along with the mucus formation. Chronic cholecystitis, definitely 90% of chronic cholecystitis will have the gallbladder stones. So the ulcerated, edematous, indurated mucosa will be seen. The thickened wall with the gray white thickened wall will be there. The chronic inflammatory cells will be seen. So the chronic inflammatory cells will be lymphocytes as well as the plasma cells, sometimes macrophages are also seen. Whenever we are discussing about the chronic cholecystitis, definitely we have to remember the four important factors, four important things that we have to consider. Whenever the wall is thickened, the cholesterol-laden macrophages are seen in the lamina propria, where we will be calling it as a cholesterolosis. And the gallbladder stones are frequent in this chronic cholecystitis. So the inflammation is variable with occasional mucosal outpouchings. So most of the occasional mucosal outpouchings, there we will be calling it as a Rokitansky-Aschoff sinuses. Rarely there is a mural dystrophic calcification will be seen, where we will be calling the gallbladder as porcelain gallbladder. Another one, the fibrous nodular gallbladder with marked histiocytic inflammation in the lamina, where we will be calling it as a xanthogranulomatous cholecystitis. So in case of chronic cholecystitis, definitely we have to remember the four things. We have to remember the four small topics which are very important for the multiple choice questions. So definitely one is cholesterolosis. So where the macrophage laden cholesterol-laden macrophages will be seen in the lamina propria, where we will be calling it as a cholesterolosis. So the inflammation is variable with occasional mucosal outpouchings, where we will be calling it as a Rokitansky-Aschoff sinuses, and the mural dystrophic calcifications, where we will be calling it as porcelain gallbladder. The fourth one is the fibrous nodular and histiocytic inflammatory cells will be there, where we will be calling the gallbladder as xanthogranulomatous chronic cholecystitis. So most of the time in chronic cholecystitis, the clinical features, the recurrent attacks of colicky pain, upper abdominal pain, fever will be there, the vomitings, leukocytosis will be there. The complications of this chronic cholecystitis, especially the inflammation of the biliary tract, what we will be calling it as a cholangitis, sometimes sepsis, sometimes it may gives rise to perforation and empyema and fistula formation. The fistula most of the time in the biliary tract along with the small intestine. So biliary enteric fistulas may occur. So sometimes this gallbladder stone will erode into the small intestine, that will give rise to gallstone ileus. So altogether, once again, the complications of this cholangitis, sepsis, perforation, empyema, and enteric fistulas and gallstone ileus due to the impaction or erosion of gallbladder stone into the small intestine. Next, carcinoma of gallbladder. Most commonly, it is seen in more than 70 years female. So always, these gallstones coexisted in 95% of the cases, especially in US, United States. These gallstones will be seen in 95% of the carcinoma gallbladder, which is a rare condition. Chronic gallbladder inflammation, with or without stones, is a critical risk factor for occurring the carcinoma gallbladder. So most of the time, the carcinoma gallbladder, the molecular pathology revolves around the HER2 gene is the 30 to 60% overexpressed, as well as the chromatin remodeling genes, especially PBRM1 as well as MLL3, are responsible for giving rise to the carcinoma gallbladder. So morphology, definitely it may be infiltrative type, fungating type, or exophytic type. Exophytic type is a growth resembling the cauliflower growth. So histologically, it may be papillary, it may be infiltrating type, can range from well differentiated, moderately differentiated, or poorly differentiated carcinomas. So the histological type may be a squamous cell type, maybe adenosquamous, maybe carcinoma, or sometimes mesenchymal variants. Its spread is local spread to the liver and other biliary tract, some cystic duct, and to the latent or distant metastasis to the peritoneum, even to the lungs. So most of the time, as we take the clinical features into consideration, this carcinoma gallbladder insidious in onset, we cannot differentiate from the clinical features pertaining to the chronic cholecystitis. Tumors are always unresectable when it is discovered. So this is the good picture of gallbladder with exophytic growth. So it's a gray white growth with the hemorrhages, necrosis, and all. The second picture is the histology of carcinoma, adenocarcinoma. So the glands, the epithelium is showing pleomorphism, hyperchromatism, and plenty of mitotic figures. So this is the poorly differentiated carcinoma arising from the gallbladder. This is adenocarcinoma. So we find whenever an elderly, especially beyond 7 decades, a female, the history of stones may be there. So usually ultrasound gives rise to or the biopsy or something else. Some MRI also it gives rise to the diagnosis. Whenever the tumors are unresectable when it is discovered, very poor prognosis it has got. Thank you.